I'm Michael Battelle, President and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with MASLD and MASH by advocating for access to approved treatments and care. Today, I have two very special guests, Madeleine Chang and Dr. Mazen Noureddin. Madeleine is a high school senior from Orange County, California, who has a strong interest in biology and medicine and has been working with Dr. Noureddin on MASLD research for the last 2 or 3 years. We also have Dr. Mazen Noureddin, who is a transplant hepatologist and established the state-of-the-art Houston Research Institute. He's internationally known for his research in MASLD and MASH and is an expert in non-invasive testing and biomarkers. Together with other notable authors, including Dr. Naeem El-Khoury and the late and very missed Dr. Stephen Harrison, they wrote a paper that was very recently published in Clinical Gastroenterology and Hepatology titled Degree of Discordance Between FIB4 and Transient Elastography, an application of current guidelines on general population cohort. So first, just talk about the topic here, Madeleine and Mazen. FIB4 as a first-line non-invasive liver test has gained popularity and recognition in all the guidelines for MASLD and MASH. So the paper that you worked on together is very important for so many people. But before we talk about the science, let's talk about the Chang family. Madeleine, tell me about your brother Devin and how you got started in all this.
Yeah, well, first of all, I just want to say thank you, Michael, for this wonderful introduction, very extensive. Okay, so so I guess I can first start talking about how I got into MASLD research with Dr. Noureddin. So initially, like my brother and I, we were both in, so I've always been very interested in biology, medicine, and research. And so has my brother Devin. And we were interested in doing research. And we started off working with the NHANES database because it's like a publicly accessible database that contains a lot of health information. And in the NHANES database, there's a lot of liver-related information, including FibroScan, blood tests, BMI, all that. And so we decided to focus our research on fatty liver disease. And after that, Devin, well, he's older than me, so he first got in contact with Dr. Noureddin, and he they worked together. He approached Dr. Noureddin first and had a project idea, and they started working together. And I kind of saw them working together, and I wanted to get involved myself. So I asked Dr. Noureddin to be my mentor, and he graciously accepted. And so since then, Devin and I have both been working with Dr. Noureddin on MASLD research.
It's just so incredible that the two of you together, still in high school, are doing something like this and really setting the bar pretty high for your peers, right? That's what I think. Mazda would say the
Yeah,
same, I'm sure.
Michael, let me uh, this is I think the podcast today, it's about Madeline and her work. Um and she's very humble. She didn't do herself or Devin justice, but I recall Devin reaching out to me and wanting to work. And as you know, like we come across many people and we try to help as much as we can. But to my surprise, Devin was already an expert in AI and machine learning. And uh, I double checked on that phenomena with another biostatistician from UCLA, and he told me Devin is the real deal when it comes to AI, machine learning, and he knows his biostat very well. So since then, Devin has published first author hepatology paper, as well as multiple other papers and abstracts that presented in the ASLD, AGA, and EASL. And then it was an easy decision when Madeline, she came, as like, can you mentor me as well? And the great thing about them, they have the ideas. I just tweak it a little bit. They know their biostat, they know medicine and the energy. I mean, I think to a certain degree I'm inefficient, but they keep, texting me and emailing, where are you? Send me this, send me that. So I love that. And honestly, like we do a lot of scientific work and presentation, but people like Madeline and Devin keep us going every day, and they make you proud and make make you feel like you're giving back to brilliant people like this. So glad she's here, and glad you're having her on your show and highlighting people like this, superstars, that they will shape our future.
In a
Well,
way, this time, Mazen, you're like a cameo appearance. So, because Madeleine's the star on this one, she's got the first billing. I wanted to speak with both of you because I do think that the topic is important. And, I read the paper, and maybe Madeleine, uh, like you guys can talk about it together here, of course, but Madeleine, maybe start and just say, you talk about in the paper about the guidelines and how it's pretty standard after some biomarkers to do a FIB4, and then after getting a fiber scan done or a VCTE of some kind. And so, why is this paper bringing to light some important issues? What did you find?
yeah, so first to explain the paper, essentially the purpose of our paper is to be an evaluation of the 2023 AGA ASLD clinical care pathway. And this pathway is like a recommendation for primary care physicians in order to identify MASLD patients that are at risk for advanced fibrosis. And so what we wanted to do in this paper, and it utilizes FIB4 as the non-invasive test in order to do this risk stratification. So we wanted to identify the accuracy of FIB4 by comparing its risk stratification to FibroScan results and identifying the degree of discordance between these two tests. And so what we ended up finding is that 10% of patients that were being stratified as low risk according to FIB4 were in fact not at low risk according to FibroScan. And more importantly, a third of those patients were actually at high risk. And so this potentially means that patients, that primary care physicians are maybe missing certain patients that have advanced fibrosis and not granting them the necessary treatments or medications that they could have. And on the other side, a majority of patients, over 60%, are being misclassified as high risk according to FIB4 when they're in fact at low risk according to FibroScan. And this false positive is not as critical because under the clinical care guidelines, they would be correctly stratified after being referred to hepatologists and then getting FibroScan data. But yeah, the purpose of our study is to kind of highlight these limitations with the current guidelines, as well as to identify the characteristics of patients that are more prone to being misclassified.
I mean, you're right about the stratification criticality. One of the downsides is that it's going to jam up the specialist offices for patients who probably don't need to be seen, right?
Right.
That's what you found as well. I don't know. Imagine, what are your thoughts?
Yeah, so Michael, the one thing I want to emphasize that um, I think the clinical guidelines pathway has been very important, and hopefully it moved the needle in terms of screening the population. We had no screening before, right? And people were the high risk was not recognized, which a lot of them they showed up in our offices with cirrhosis. So the big thing is we're supportive of the guidelines. We're supportive of starting with FIB4 as well as following by the FibroScan. But even if when you put recommendation like this, you want to look at the false positive, false negative coordinations, because research is a moving target. FIB4 is cheap, straightforward, but that doesn't mean that we don't try to improve it or bring newer things that is as cheap as the FIB4. So that was the whole idea. And Madeleine led that paper, and she can tell you about the findings that I guess what we wanted to say, pay attention. It's not always it just do not like have a tunnel vision, or is it vision tunnel, whatever it is, that you don't you do it FIB4 one time and you're done after that. Maybe repeating FIB4 is the way to go. Maybe having another test such as the machine learning that we mentioned Devin worked on is the right way to go. It's like it's not easy, but one day we'll have these machine learnings implemented in medical records that you don't have to plug in numbers, it will spit it out for you. So that was the thinking and the theme that we have been working on. And I'll pause back for Madeleine to take the stage.
Yeah, Madeline, and about that. So you did find in the paper too, which I think is really important, because the conclusion was that one of the conclusions was that there was a relevance with regard to comorbidities, right? Like pre-diabetes or type 2 diabetes, BMI, waist circumference, all of those things. So the interesting thing is that the guidelines are not to do really general screenings in communities, probably for exactly this reason. But you've actually confirmed that, because the data that you looked at were patients that were already had some sort of comorbidity, and yet you did find that relationship, confirming that patients who had the comorbidities were way more likely to be accurate than the ones who didn't. Is that right?
Right. So, what we did find is that patients that are more prone to being um, misclassified as by the guidelines are patients that have type 2 diabetes and have some of those comorbidities.
They were the ones who were misclassified, or they were the ones who
Yeah,
Yeah,
patients that
so
are,
so
oh,
Michael, if I would jump in,
sure.
I think we just followed the guidelines
Yeah.
pathway. We did not look at the non-risk population because, as you know, this is something we don't need to look at. I think the gist of it is, okay, let's apply the AJ and ASLD and see what comes out. So what Madeleine did, she did the pre-diabetes, diabetes, two metabolic risk factors, and elevated liver enzymes, and she applied the FIB4 followed by transient elastography, and there was a misclassification,
Right.
not huge, but and we can go into the numbers and we can put that graphical abstract. I think it's very informative. But I think the gist there was it's great that we have screening guidelines, but we can misclassify some patients. And this is not new, Michael, right? So the people talked about like the diabetes and the performance of FIB4 and the diabetes in particular, and if we should lower or increase the cutoff. So we just wanted to apply these algorithms and see what we come up with. And we came up with the findings in the CGH paper.
So in the real world, then, what's the recommendation that you would make now to people? To continue doing what they're doing? Uh, what do you think?
yeah. So, as Dr. Noureddin said, of course, FIT4 is currently we do recommend the usage of the clinical care pathway. Although we did highlight some of the limitations in our study, currently FIT4 is a highly effective and widely utilized and just cost-effective test that is accessible to primary care physicians. So we do recommend to continue on with the pathway. As Dr. Noureddin mentioned, like we're just suggesting the idea of exploring possible alternatives, such as we highlighted in the paper, SafeScore, MASEV, NIS2, and machine learning models. So right now, we also recommend primary care physicians to be aware of the uh, characteristics that may make a patient more prone to being misclassified. So as we highlighted, patients that are greater than 63 years old, have BMI greater than 40, and to just be aware that there is the possibility of misclassification. And we can overcome this limitation by having annual or biannual testing,
Right.
as we highlighted in the paper.
Okay.
And let me give a specific example, Michael, from the visual abstract. For instance, let's focus a little bit on the low FIB4, right? Less than 1.3. So in that group, again, we rule out other causes. We focus on type 2 diabetes, pre-diabetes, two metabolic risk factors, and elevated liver enzymes. So what Madeleine did, she started the same as algorithm, but without going into the super details of the paper, let's talk about just the low risk FIB4, which is less than 1.3. So the comparison was not a biopsy, was transient elastography, because that's the only thing available in the data set, which is great information, right? But when Madeleine looked at those with low FIB4, less than 1.3, and let me give you the total number, there was about 2,500. When she looked at low FIB4 less than 1.3, but they had more than 8 kPa on the transiloscopy, right? So we think transiloscopy is more accurate than the FIB4. So these people, although they were classified low, she found that 10% of these people had kPa more than 8. And this is one of the key findings in this paper to me. I mean, I told you the entire group, the low FIB4 were risk of, they were 2,500. So 10% of them with having FibroScan more than 8 is not trivial. And if you want to translate that in the general population, so we can misclassify a lot of patients, despite the 10% is on the lower side, despite the fact that it'd be cost effective. But I don't want to be a patient who has low FIB4 less than 1.3, while my FibroScan transiloscopy or more than 8, and I might have a real risk factor. We also looked at more than 12 and all these things. So I guess this is the thoughts that we had. Okay, so do not just, at minimum as of today, do not just look at one-time FIB4. If they still not making sense to you, that like type 2 diabetes, hypertension, dyslipidemia, and overweight is like one-time FIB4 might not be sufficient for them. We might need multiple. If you have a transient elastography in your office, do it. If you have another blood test, do it. Do not miss these patients. And of course, there's more research to be done and do most cost-effective analysis. We previously showed in a gastro paper that just started with transient elastography by itself is cost effective. So we did not even start with the FIB4. I think the regulators, or like the people that they put the guidelines, they wanted to make sure the test is available. Not everyone has a FibroScan, so they started with the FIB4. But start with the transient elastography already have shown that you do not affect cost of a society. And to me, like for instance, if I have type 2 diabetic in my patients, I do not start with FIB4. I go straight to transient elastography. So be cautious on the low FIB4, for instance. It's one of the key things in this paper. And we should not stop the research just because we have a FIB4 now implemented guidelines. Let's keep challenging the status quo and improve the science.
And you made a good point too, that just now, that in time we probably will need more VCTE sites so that we can do more of that, right? I think both of you would agree with that. Is that like,
Yeah, or blood tests, right,
or
Michael? So there are
or
blood tests
advanced blood
out
tests? Yeah.
there. There is the ELF. There are a couple of tests that one became available, commercially available, the Massive Score and the NIS2. We're waiting for it to be commercially available, and people are still doing research. We don't probably need keep looking for 300 other tests, but I think like the 3-4 promising candidates, we need to deepen the research in these areas, correlate them with outcomes, correlate them with treatment for response. So I still invite the government agencies, NIH, the pharmaceutical companies to invest on these NITs, especially when we complain about not enough things available in the market or not enough tests available to design clinical trial with biopsy. Yeah, we have a lot there. Focus on the 5 and 6 that is gonna tell us the story and keep increasing the data. Transient elastography has a lot of confidence because the data now in the thousands of patients, right? MR elastography is falling behind because it's expensive and not available. The data is in 100, but still there's data. So I think it's the investment in blood tests, especially the promising ones, is one of the messages out there, especially on the screening level. I mean, machine learning could be quite cheap, and everything is moving toward that, and the world has changed. We didn't have electric car, now we have electric cars. That is the most
Definitely.
expensive company in the world. So why machine learning is complicating clinical practice? We can master that.
So we got Devin and Madeline are going to be taking over the world, basically, right? We got Devin leading the way with machine learning, and Madeline. So, are you going to pursue medicine? Should I put you on the spot?
Well, most likely, yeah. Right now, I'm in the process of college application, so first we'll have to see where I go, and then
Okay.
but I'm gonna be majoring in biology, so most likely.
And no pressure. Devin got acceptance in Stanford and Harvard, and he's going to Harvard. So, hint to Madeline and people out there watching, who's Madeline?
Yeah, absolutely. I thank you both, Madeline. I wish you only the best. It really, I talk to Dr. Noureddin all the time, but it was you that I really wanted to talk to and see what makes a high school student and family want to do something like this. And you answered the question, and thank you for your passion and your love for making a difference in the world. Thank you.
Yeah,
Yeah,
for sure. Thank you, Michael.
congratulations on your first author paper. And also Madeline will be at the ASLD. She has a poster presentation in San Diego, and she told me she's going. So you need to meet Michael at San
I'll be
Diego.
there. We'll
For
do that.
sure. Yeah.
We'll
I'll
do
see
that
you
for
there.
sure. Thank you.
All right. Thank you guys so much.